Thank you all for joining us today. We'll get started in just a few minutes and allow everyone a chance to join. Thank you all for joining us today. We'll get started in just a few minutes and allow everyone a chance to join. Thank you all for joining us today. Thank you all for joining us today. We'll allow everyone a chance to join and get started momentarily. Thank you all for joining us today. We're going to get started now, and I will turn it over to ASH Chief Operating Officer Elizabeth Ferguson.
Thank you, Megan. Good morning or good afternoon to everyone. Thank you so much for joining. I'm Liz Ferguson with Action on Smoking and Health. And thank you again for joining us today for our webinar. Could international human rights obligations motivate countries to implement tobacco cessation support? Well, here at Action on Smoking and Health, we're hard set on making sure that all tobacco control advocates know that the production, marketing, and sale of cigarettes is a human rights violation. Once they know that, we train them on how to use existing human rights systems to encourage their governments to enact stronger tobacco control regulations. But what does it mean for people who are already addicted to nicotine through these products? We know that the majority of people who smoke want to quit, and we know that they've probably tried to quit multiple times. Nicotine is just an extremely difficult drug to quit, so we must increase our efforts to help them quit. And how can we motivate governments to further implement cessation support? Today, joining us, we have Martin Raw, Director for the International Center for Tobacco Cessation and visiting research professor at the New York University School of Global Public Health. He'll provide us with an overview of the WHO Framework Convention on Tobacco Control, Article 14, which involves cessation and treatment, which will also help implement effective measures to help tobacco users quit. He'll also talk with us a bit about obligations to further support other evidence-based policies. We'll also be joined by Benjamin Mason Meier, who's a professor of global health policy at the University of North Carolina at Chapel Hill. We'll talk with him about the UN human rights system, how it could provide a basis for monitoring state obligations under Article 14 of the FCTC. Unfortunately, our colleague Kelsey Romeo-Stuppy will not be able to join us today, so Chris Bostic, the policy director here at ASH, will join us to discuss practical examples of how we can utilize the human rights system for advocacy, as well as several other upcoming opportunities. But before we get started, I'd just like to remind everyone that we will be taking questions in the Q&A box at the bottom of your screen, and we'll take those at the end of our program. And also, if for any reason you'd like to have the presentations to view again after today, we will be emailing those around. So please look out for those over the next day or so. And with that, we'll begin our presentation from Martin Raw, who, in order to avoid some other technical difficulties, we will be showing a video presentation. He is here with us, but we're going to be showing a video of his presentation to keep things smoother on our end. So Megan, I'll transition over to you to begin that recording.
To this webinar, I'm going to thank you very much for inviting me to contribute to this webinar. I'm going to speak briefly about the Article 14 obligations on cessation support and then make a few comments about implementation. The main articles of the Framework Convention each have a guideline for implementation. The Article 14 itself is very short, and so the guideline is to give much more detailed guidance to countries on how to implement cessation support. The Article 14 guidelines have three main sections: developing an infrastructure to support cessation, the key components of a treatment system, and a stepwise approach to introducing treatment. Developing an infrastructure includes doing a national situation analysis. Basically, look at the resources you have, look at the resources you need, and construct an analysis of where to go next. This is likely to include developing an official strategy and national guidelines. And I'll show some data later showing that not many countries yet have those. Address the issue of tobacco use in healthcare workers, still a very, very important issue. Make recording of tobacco use in medical notes mandatory. And then ensure that all tobacco users are provided with at least brief advice. And then the key components of a treatment system. Mass communication to encourage cessation, because there's not much point in having a treatment system if people don't know about it and if they're not motivated to go and use it. Integrate brief advice into all healthcare systems. Quit lines, although I'm going to make a comment about quit lines and text messaging later. Then specialized treatment services and the provision of medications. And then the stepwise approach. And the point of this is to encourage countries to start with whatever they can do with resources they have at the moment, starting with implementing those articles that increase demand for cessation, which I already mentioned, and to use existing infrastructure as much as possible. Excuse me. Obviously, in order to keep costs down, but also because many countries have very well developed primary care systems, for example, and TB treatment systems. And then strengthen national coordination and funding. And funding, of course, will always be a challenge. And then disseminate national strategy and official national treatment guidelines. Now, the second part I want to draw attention to of a stepwise approach is addressing the issue in healthcare workers. Incorporating cessation into the core curriculum of training courses for doctors, nurses, pharmacists, and so on, training healthcare workers and other relevant workers to give brief advice, and then helping them to quit. Now, these are old data, but they're quite dramatic, and they show incredibly high rates of tobacco use in health professionals. For example, just look at Slovakia, second from bottom, nearly half of GPs using tobacco. But they are very old data. So our group did a survey of prevalence of tobacco use in healthcare workers. a systematic survey and meta-analysis. First thing to say about it, perhaps, is that it was very, very difficult indeed still to get up-to-date studies. It's a very, very neglected area. So we covered nearly 230 studies between 2000 and 2016, nearly 500,000 healthcare workers in 63 countries. The overall average of tobacco use was 21%, which is still fairly high. But look at the highest rates. They're incredibly high still, 35 to 45%. And the highest rates were in male doctors in upper and lower middle income countries. So there's a huge amount to do even at the most basic level of getting healthcare workers, who are a model for many, many people, to stop using tobacco. Now I'm coming to look briefly at our survey data. We surveyed countries on implementation of Article 14. Again, the data are now a little bit out of date, but they do show how far there is to go. I won't mention all of these, but look at the bottom figure, which is only, this is in 2015, only a third, less than a third actually, of countries mandate recording tobacco use in medical notes. One of my earlier slides mentioned identifying tobacco users as the obvious first step in then giving brief advice. So if you're not even identifying them, you can't give brief advice. That to me is still a shocking figure. And then fewer than half offer healthcare workers help in stopping, or have national treatment guidelines, or a national treatment strategy. So what should countries be doing now? Excuse me. They should be doing the national situation analysis, reviewing their resources available, and then seeing where treatment fits into their overall tobacco control program. They should start with core infrastructure measures, identifying a budget, having an officially in charge of policy, having an official strategy, and having official guidelines, and then mandatory recording of tobacco use in medical notes. They should prioritize broad reach, low cost approaches. Brief advice, the most important, or the most obvious perhaps. I've put a question mark after quick lines because quick lines are not cost free. Data on their reach is not so impressive. You might imagine they would have very, very broad reach, but they don't necessarily. And there are data now showing that text messaging, which is incredibly cheap in principle, can get much, much wider coverage. And then access to affordable medications. And I'm sure that the perceived concern about cost of medications is at least one of the reasons for reluctance to fully implement Article 14. And we may have time possibly to discuss cytosine there, which is a very, very cheap cessation medicine, which has been on the market in Europe for more than 60 years. It's safe, it's effective. A full treatment course is less than $30. So there are affordable medications. And then you move on to more specialized support if and when you have the resources. So you could express what countries should be doing now much more succinctly. What they should be doing is they should be implementing the Article 14 guidelines, but they're not, or at least they're not quickly enough. There are many reasons for this, which we could discuss, but perhaps more important, which is the subject of the next talk, what can be done to improve implementation? Thank you very much.
Thank you, Martin. That was Martin Raw, Director from the International Center for Tobacco Cessation. Excellent presentation. And to our participants, please be sure to send your questions through the Q&A at the bottom of your screen. Next, we'll transition over to Benjamin Meier, again, Professor of Global Health Policy from the University of North Carolina at Chapel Hill. Ben, over to you.
Thank you so much. And as we shift from cessation efficacy to human rights, I hope to address the ways in which the FCTC reaffirms the human right of all people to the highest attainable standard of health as a human right. And while the FCTC has achieved some success in limiting the initiation of tobacco use, Article 14, as Martin just discussed, has been less effective in promoting the adoption of policies to successfully improve cessation measures and to ensure that tobacco users receive support to free themselves from harmful addictions to tobacco. As a consequence, I'll argue that tobacco users have been denied their inherent dignity and their fundamental rights. And so good morning, good afternoon, good evening. As the human rights scholar on this project, this collaborative research, and our new article that's just come out in Addiction, I hope to lay out the state cessation obligations that exist under the right to health and the international accountability mechanisms that have been developed under the UN human rights system. Laying out the human rights foundation for our discussion today, I hope to discuss how international human rights law, as Liz said, can provide a path to recognize tobacco cessation as central to tobacco control, supporting addicted populations throughout the world. With the right to health supporting efforts to free people from harmful addictions, I hope to examine how health and human rights accountability mechanisms can work together to support Article 14 implementation, framing tobacco cessation as a human rights obligation. Now, under the right to health, I want to begin by recognizing where this arrives from in the 1946 Constitution of the World Health Organization, which became the first international legal agreement to proclaim a unique human right to health. And in structuring WHO's mission under the right to health, its preamble declares forcefully that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, defining health positively to include a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, to implement this expansive, positive vision of health, a vision that was in line with public health's contemporary focus on underlying determinants of health, this preamble would further declare that governments have a responsibility for the health of their peoples, which can be fulfilled through both the provision of adequate health measures and social measures. Now, through these far-reaching legal principles, the WHO Constitution, supported 2 years later by the Universal Declaration of Human Rights, would encompass the aspiration of nations to build a healthier world out of the ashes of the Second World War. And in laying a foundation for the evolution of the right to health over the past 75 years, a 75-year evolution that we've chronicled in the 3 books that we've developed over the past 5 years, has helped to shape what has now become a growing movement for health and human rights. Now, through this movement for health and human rights, framing some of my interdisciplinary scholarship, I focus on human rights under international law as a basis for public health. By framing public health threats as rights violations, international law over this 75-year evolution now offers global standards by which to articulate the obligations of governments, to evaluate the policies and outcomes that are achieved under law, and to shift the tobacco control debate from one of political aspiration or moral claim to one of legal accountability. This health and human rights movement has offered universal standards by which to frame government responsibilities and to facilitate legal accountability. Even as the tobacco industry has increasingly been seen to try to co-opt human rights rhetoric. And in the article, we discuss how the tobacco industry has cynically employed the language of rights and choice to advance its corporate objectives. we recognize that human rights is not simply about choice, but the obligation of governments to support individuals in making healthy choices, to help individuals to free themselves from addiction to harmful tobacco products. In this context, international human rights offer a powerful policy discourse, providing international standards by which to frame government responsibilities for cessation policies under the FCTC. And so my presentation recognizes the need to realize human rights through tobacco cessation support, freeing individuals from tobacco addiction where that addiction endangers health. And I'll open by examining at the beginning how addiction limits individual choice, undermining health autonomy that is central to the right to health. As Liz mentioned, people want to quit, but they cannot. And so we need to talk about addiction. And if addiction undermines the right to health, then cessation can realize human rights. And I'll then shift to examining how international legal obligations under the human right to health can begin to ensure access to tobacco cessation. Now, I'll end by seeking to understand how we can strengthen accountability for the progressive realization of these rights in cessation policy, talking about the stepwise approach that Martin began discussing just a few minutes ago, and considering how human rights monitoring under the United Nations human rights system can support implementation of effective tobacco policies. And I hope to signpost at the top where I am in this presentation. Recognizing at the end that where improving tobacco cessation will require a coordinated effort across human rights and global health governance, we need to come together to realize the highest attainable standard of health. And I'll end by looking to human rights monitoring mechanisms as a way to facilitate state accountability for cessation policy. Now, beginning under human rights law, we recognize that the right to health upholds an entitlement to the conditions that will maximize the potential for individuals to enjoy health, the freedom of individuals to make healthy choices. And yet the use of tobacco is shaped by the tobacco industry, which, as we mentioned in the article, has manipulated the chemical, sociocultural, structural factors that enhance nicotine addiction and undermine individual decision-making. We recognize, as I mentioned earlier, that despite a widespread desire to quit, few will achieve long-term abstinence without support because of this industry manipulation. The use of tobacco, often initiated in adolescence but maintained by addiction, is not an informed and voluntary choice consistent with the right to health. The right to health, therefore, imposes an obligation on governments to safeguard the right to health of those addicted to tobacco, supporting individual autonomy, supporting healthy behaviors, supporting vulnerable populations through the progressive realization of tobacco cessation policies. Under the right to health, states, individual governments bear international legal obligations to facilitate environments in which individuals can make free and informed decisions about their health. In 2000, the UN human rights system, just prior to the FCTC, found that states bear obligations to discourage the consumption of tobacco. And then recognizing the ways in which individual choice is impaired by youth targeting, by industry marketing, by addiction manipulation, states need to progressively realize measures to protect individuals from these corporate influences, from this corporate interference with healthy decision-making, adopting measures that can support cessation. Cessation can support individuals to overcome the influence of nicotine addiction and to support the restoration of individual autonomy over health. In this way, cessation is uniquely supported by the human right to health, as among tobacco control measures, only adult cessation really provides significant short and medium-term population health benefits. And yet, as Martin discussed, reports on FCTC implementation have continued to show that states have prioritized population-level prevention measures while really neglecting individual cessation support under Article 14, where these prevention efforts alone are insufficient to realize the inherent dignity of vulnerable populations addicted to tobacco. This cessation support should be seen as central to realizing the right to health. To restore individual autonomy under the right to health, states have looked to cessation measures under Article 14 here to promote tobacco cessation and ensure tobacco dependence treatment. But where many states have neglected to implement Article 14, they failed to establish policies to progressively realize the right to health through cessation support. Given this implementation failure that Martin addressed so forcefully, how can we look to international monitoring as necessary to facilitate accountability for the progressive realization of the right to health? And so cessation, from a human rights perspective and from a clinical perspective, we recognize that it can't be realized instantaneously. States need to take steps progressively over time to implement cessation support through a step-up approach that Martin discussed. Given this progressive realization to realize the right to health, efforts to facilitate accountability for these changes will require periodic assessment over time, which can be provided through both complementary monitoring mechanisms in global health governance under the FCTC and simultaneous human rights monitoring mechanisms through the United Nations. Where the FCTC monitoring systems are seen to lack engagement from civil society, to lack constructive dialogue with government representatives, to lack discrete recommendations to review implementation, we recognize that FCTC monitoring systems have largely ignored cessation through the World Health Organization. And so how can we look to human rights monitoring through the UN human rights system to ensure that there is accountability through monitoring? I hope to lay out at the end the ways in which human rights governance can provide complementary monitoring mechanisms, applying international pressure on governments and holding states accountable for the progressive realization of health-related human rights. In facilitating accountability for human rights obligations, to support tobacco cessation, UN systems for human rights monitoring are exercised through the three different instruments mentioned here on the bottom left. And beginning with human rights treaty bodies, which I hope to be the focus of my discussion here, we recognize that various UN committees, specific human rights treaty bodies, are responsible for reviewing implementation of the right to health. And these treaty bodies have issued reporting guidelines to frame state periodic reporting. They've looked at the FCTC to frame tobacco control obligations under the right to health. And they provide a basis through a recurring system of monitoring and review to ensure the progressive realization of the right to health. And here we see on the right the ways in which states are reporting to treaty bodies, the ways in which treaty bodies are engaging in constructive dialogue with national governments, thereafter developing concluding observations which note state failures and limitations, and then having implementation and follow-up mechanisms. And so while these systems rely upon state self-reporting, we recognize that these human rights institutions also have the ability to consider independent reports from civil society, or what the human rights community has come to call shadow reporting. This reporting provides a sense of what is happening at the state level, providing treaty bodies with a way to review state efforts, to recommend human rights reforms, and to question governments where they fail to meet their obligations. In comparison to FCTC reporting processes, we recognize that these human rights processes, which have existed far longer, are now seen as more robust, more analytic, and more impactful in shifting state behavior. And this complementary review process can provide an assessment of the state's progressive realization of human rights in the context of cessation support, with monitoring practices allowing treaty bodies to recognize best practices in cessation policy, assessing weaknesses at the national level, and facilitating accountability through naming and shaming recalcitrant states, reviewing implementation publicly, publicizing national limitations, and motivating state action. And so as we reflect on this article that we've developed in addiction, we recognize that the FCTC offers a framework to interpret state obligations for progressive realization of the human right to health, with Article 14 and its guidelines providing a framework to clarify state obligations to those addicted to tobacco and in need of cessation support. But where Article 14 implementation has been limited, human rights opportunities in the upcoming Conference of the Parties can highlight the need for cessation support as part of an effective rights-based approach to tobacco control, aligning, as Chris will discuss, the ways in which global health obligations under the FCTC and human rights obligations under the right to health can support cessation monitoring and review to ensure accountability for cessation support. To accelerate cessation support, the tobacco control and the human rights communities need to work together, we argue, to advance cessation obligations under the right to health and to provide complementary accountability processes under the FCTC and human rights law. Thank you so much. I look forward to discussing this with you shortly and turn the conversation, I believe, back to Liz and then over to Chris.
Thank you, Ben. That was an excellent presentation. Ben Meier from the University of North Carolina, Chapel Hill. Next, we'll shift over to Chris Bostic, our policy director from Action on Smoking and Health. He is kind enough to stand in for our colleague, Kelsey Romeo-Stuppy, who is unable to join us today. And Chris will provide us with some practical applications to this cessation topic today. Chris Bostic, over to you.
Great. Thank you, Liz. Forgot to unmute there for a moment. Hello, everyone. Thanks for joining us today. I'm going to be talking mostly about how we can use these human rights mechanisms and arguments to advance local tobacco control regulations. But it's not just local, it's state, it's national. But I won't go into some of the international mechanisms that Ben just so thoroughly covered. Let me just start by looking at the obligations that governments have under a slightly different way than Ben just gave us. There is actually no international human rights treaty that deals with transnational corporations. There is a negotiation underway right now that will. But in the meantime, the UN Office of the High Commissioner of Human Rights has promulgated these guiding principles on business and human rights. And at their center is a framework called the Ruggie Principles, and it's the Protect, Respect, and Remedy framework. The Protect applies to governments. Governments have a duty to protect their citizens from third parties, in this case, the tobacco industry. Respect applies to industries. And when the industry does not respect human rights, it bounces back to protect. In other words, governments don't just have a duty to not violate human rights, they have a duty to protect their citizens from violations of human rights. And then the remedy, of course, applies to victims of human rights abuses, and there must be mechanisms in place to make them whole. So this is the basic human rights argument. And this focuses on life and health, but there are many other human rights involved here. It starts with everyone has this right to life and health. Governments have a positive duty to enforce those rights against third parties. Therefore, governments have a duty to protect their citizens from the tobacco industry and the harms from tobacco. And they have an obligation to put mechanisms in place for legal remedies at all levels. So to just change that slightly to talk about cessation. Everyone has a right to health, and that includes being helped to quit smoking. And in addition to governments having this positive obligation to protect their citizens, there's a moral obligation as well, and it comes from several angles, but I want to focus on just one very quickly, and that is that given that that governments have not lived up to their human rights obligations in the past and allowed the tobacco industry to prey mainly upon children with an addictive and deadly drug, governments really have an extra duty to help people that have been in that situation to get off of smoking. So there's an obligation in several ways here. So governments have this duty to enforce those rights, and that includes helping citizens to quit. And of course, as Ben said, The right to health is the right to the highest attainable standard of health. And every government has the ability to provide some level of cessation support. So it is clearly attainable. So governments therefore have a duty to protect their citizens from the industry by providing cessation support. And if governments don't provide that support, there should be legal remedies available. So I'm going to talk a bit about the US because it's a little bit different here. The US tends not to ratify human rights treaties, although we have done some. We've not ratified the FCTC, although we signed it in 2004. We have not ratified the International Covenant on Economic, Social, and Cultural Rights, or on the Convention on the Elimination of All Forms of Discrimination Against Women, or on the Convention of the Rights of the Child, although oddly, we have ratified two protocols to the Convention on the Rights of the Child. And I also wanted to point out that in the United States, we often don't talk about human rights, but instead about health equity. And I think for our purposes, those things can be seen as the same. What we have ratified is the International Covenant on Civil and Political Rights, and then the International Convention on the Elimination of All Forms of Racial Discrimination, or CERD. And I think this has come into play quite a lot recently in the past few years in our efforts to get menthol off of the market, which I'll talk about next. As I'm sure almost everyone listening knows, menthol has for decades been targeted at certain communities, in particular the African-American community in the United States, to the point now where something like 85 to 90% of Black smokers use menthol cigarettes, and it's been advertised as sort of the Black cigarette. And so the outcomes for the African-American community are terrible because of the existence of these cigarettes. In 2009, when Congress finally gave control of, or at least the regulation authority to the FDA over tobacco, they banned all flavors except for menthol. But in the law that they gave to FDA, they told FDA to look at menthol as a priority, and if it determined that menthol was bad for public health, that it should also promulgate a rule to ban that. That was in 2009. In 2013, they still had done nothing, and a citizens petition was put forward by a large number of groups of tobacco control organizations, reminding the FDA of their obligation and urging them to move forward. Legally, the FDA was supposed to respond to that citizens petition, but they never did. So we had to go to the courts, and this was the African American Tobacco Leadership Council, and ASH had the pleasure of joining them as a plaintiff, and later the American Medical Association and the National Medical Association joined. We sued the FDA, trying to force them to at least respond to that citizens petition and to also ban menthol, and the court agreed. And so last year, FDA did promulgate a rule on banning menthol. That is still in process. It is the FDA, it is the federal government, so it's going to take a while, but we're hopeful that in the next few years we can get menthol banned at the national level. And just a note to all of our advocates at the local and state level, please don't stop working on menthol issues, because we don't know when it's going to happen, and lives are in the balance. So that's a real life example of how you can use these things. I'm going to talk just a bit about our monitoring and reporting systems. So we promulgated some letters to the International Committee on the Elimination of All Forms of Racial Discrimination, bringing up menthol, and this has been done several times now from multiple countries. And fortunately, now the committee has mentioned menthol several times in their own work, and so we need to keep doing that. We've been working with organizations around the world for several years now, and I believe we've submitted scores of reports to various human rights bodies. We need to convince the human rights community, or continue convincing the human rights community, that that tobacco should be part of their general work. That this is something that is a human rights issue from top to bottom. So it's impossible to talk about human rights without talking about human rights violations and bringing them to court. There are numerous ways to do that. I should point out that these human rights obligations do apply to national governments, but they apply down the line too. They apply to state and local governments. So there are domestic remedies in place. Sometimes governments include human rights obligations in their constitutions. In the United States, it has the power of federal law. There are regional systems in place. There's a European Court for Human Rights. There is an Inter-American Court for Human Rights. And then internationally, there are two courts, the International Court of Justice and the International Criminal Court, that we have not been able to utilize yet, but hopefully can in the future. It's quite a complicated set of options available to use human rights in courts. ASH is not the expert on this, and we don't really have the bandwidth to do this for everyone. But if you are interested in tapping some of these opportunities, please let us know, and we can at least point you in the right direction and offer some technical assistance. So some upcoming events that we need to pay attention to. The 10th Conference of the Parties of the FCTC is coming up in Panama in November, and human rights is on the agenda. And we have tried in 2 previous COPs to get a strong human rights decision. We were sort of thwarted by COP9 because of the pandemic. They were not able to address a lot of the things on the agenda, except that was very necessary. So it did not come up at COP9, but we're gearing up now to make sure that it is discussed and we get a positive decision out of the COP. There's also the third general recommendation coming up. General recommendations are when the Commission for the Elimination of Racial Discrimination puts out a white paper on a particular topic, and they are in the midst now of working on one on racism and the right to health. So it is exactly down our alley. We need to ensure that that tobacco is in there and prominently in there. This kind of thing, the general recommendation is not international law, but it's highly persuasive, and it can be used for advocacy. There are also, of course, the reporting. We've got to continue the reporting from national NGOs to various human rights commissions to continue to push human rights as tobacco as a human rights issue. And then there's engagement with special rapporteurs. And these are people that are brought in for 3-year terms to focus on a particular aspect of human rights law. And there are 42 of them, I believe, at present. And there are a number that overlap with what we're talking about, tobacco control. There's a special rapporteur for health. There's one for development, the rights of persons with disabilities, the right to education, the right to a healthy environment, the right to food, the right to correct disposal of hazardous substances, and the rights of indigenous peoples. So I'll conclude there. I think we're a little over time, and I hope we can answer your questions. Thank you for your attention.
Thank you, Chris. Excellent presentation, and thank you again for being able to step in at the last minute for our colleague Kelsey. We're very grateful for you to be able to do that. We do have a couple of questions. Some have come through the Q&A, others have come directly to me in the chat. So I'll just start with those, assuming that Martin and Ben, you're able to stay on for a bit longer so we can answer.
Yeah. Excellent.
Martin, the first question is for you, sir. What would full implementation of Article 14 look like? What's your dream scenario, and can you identify that it's a country that's done it, or some others that have come close?
Wow. I don't think I can identify any country that's done everything they should do, even so-called rich countries, high-income countries. And my dream scenario probably, no, it does recognize that not everything's going to get done quickly. So my dream scenario is every country at least recording tobacco use in medical notes, so you're making sure that the issue gets raised with every smoker, and at least delivering brief advice. Brief advice can be as little as 1 or 2 or 3 minutes, and yet that at a population level that still has a big impact. So I mean, that's not a dream scenario, that's a minimalist dream scenario. I'd like to see every country at least having an official strategy and policy on cessation support. And I'd love to see more serious action taken on cytosine, because it's effective, safe, and very, very cheap. But it's not even on the essential medicines list. of WHO. So there's so many relatively simple things that could be done quite quickly. That's a half, sorry, no, that's a half waking, half dream scenario. Sorry.
Ben?
And I would only add to that to recognize that from a human rights perspective, full implementation is not possible. And yet that doesn't mean that we can't push states forward. But what it means is that if every state needs to continue to improve their progressive realization of rights, we need to be continually questioning government efforts and continually pushing governments to move forward, and then looking at governments over time to see how those implementation efforts are moving forward, questioning not just what they've done, but how fast they've improved their efforts over time.
Can I add one comment?
Yeah, sure. I have a question for Ben after this. Martin, go ahead.
Okay, thanks. Just briefly. I mean, one of the tools we developed in our Article 14 implementation work is an affordability calculator using WHO data and World Bank data. And it allows a country to input cost data for treatment and effectiveness and calculate the affordability of treatments for that country. And it could be potentially important. I mention it because undoubtedly concerned about the potential cost of treatment, especially medications, is undoubtedly a reason for slow implementation. Not the only one, but a reason. Thank you.
Thank you. So, Ben, question for you. Why not just the FCTC? Why do we need to utilize these complementary human rights laws and mechanisms?
So that's a fabulous question. I think it speaks to the broader usefulness of the human rights lens and the human rights system. That one of the four principal pillars of the United Nations when it was first developed was human rights. That all of our efforts are seeking to realize universal rights across all people in all places across time. And human rights, both from a logistics perspective and a practical perspective, can complement what is already being done by the FCTC, but also at a more theoretical or conceptual level to recognize that when we talk about tobacco control, one of the reasons why we care about it is about individual dignity. It's about individual rights. In many of our tobacco control conversations, people who smoke or those who are addicted to tobacco are often left out of the conversation, are not seen as easy to reach, as not seen as sympathetic. And yet, if we take seriously the UN ideal that all people are equal in dignity and rights, why should we see people who are addicted to tobacco as any less deserving of rights, as any less deserving of health than anyone else? So from a conceptual level, cessation is one of those interventions that can really speak to that core commitment, that can recognize that when we say all people are equal in rights, we mean everyone. And so yes, it's about individual decisions, but those decisions, as we've all discussed, are structured by environments. Those environments are being structured on one side by corporate manipulation and on the other side by public policy. How can we change the environment to support people who have largely been neglected in the tobacco control conversation, and to make sure that we really can realize the highest attainable standard of health for all people?
Thank you. So Ben and Chris, either one of you, I think, could answer this question because you both mentioned the upcoming COP, or Conference of the Parties to the FCTC. Can you speak to how cessation might be addressed at these negotiations in the context of a human rights decision? I think you both referenced it, so the question could go to either one of you.
Ben, do you want to start?
I was going to let Kelsey start because she's really been thinking about this the longest time, but she's lost her voice. So I'm delighted that you're filling in. I think just to begin the conversation and to speak to Carolyn Dressler's comment in the Q&A, one of the things that we were trying to do in this article, and it's in the debate section of addiction, is to start a conversation. And so Carolyn was the author of one of the 3 commentaries based upon our initial article. And all of those commentaries are seeking to, in many ways, engage the tobacco control community in these human rights conversations. And with, as Chris said at the end of his presentation, human rights on the agenda for COP10, one of the questions for me is, how can we ensure, first of all, that human rights implementation supports FCTC implementation so that we are aligning 2 parallel but largely disconnected parts of the United Nations, the global health law system and the human rights law system? And secondly, how can we ensure that our focus on human rights doesn't neglect those who are addicted to tobacco, so that human rights doesn't just become a tool of prevention, but can become a tool of cessation? Chris?
I completely agree with Ben, and let me just add that it's we have actually a bigger opportunity, I think, at COP than simply a human rights decision, because of the way things are interlinked. 2 other things that are on the agenda for the COP are the environment and tobacco endgame for the first time, Article 2.1. And of course, as you know, ASH is all about endgame, and we've been saying for years that an intrinsic part of endgame is robust access to cessation support. It's simply immoral for us to take away nicotine without helping people that are already addicted to it. So we're not going to try to combine decisions at COP, but I think that we can have a broader discussion while we're there and talk about the right to a healthy environment as well as the right to life, and talk about how governments, if they are interested in entertaining endgame policies, how Article 14 has to be an intrinsic part of it.
Thank you both. Just to kind of continue on this, COP aside, the other human rights mechanisms in the various reporting processes that go with those, what can we do to really convince more people in our tobacco control, but our public health communities, to do more with these reports to the various human rights committees? And how can we, what can we be doing to publicize timelines? What kind of technical assistance can we be providing? What really more can we be doing? And this is a question from our friend Carolyn Dressler. So Carolyn, thank you very much.
Well, I can start real quick, and I just know from working with folks that this can be intimidating for a tobacco control advocate when you tell them, "Oh, why don't you put in a report to this human rights body that sits in Geneva?" But it's really not as hard as it might seem, and we have a lot of templates at ASH. We have a lot of experience with it, so just take that first step and get in touch with us, and I think you'll find that it's easier than it seems.
To shift gears a little bit, question for Martin. I think it's a really good question, actually. Why is cessation such a neglected area of our work when it's truly the main goal of just about everything that we're doing here in tobacco control?
Sorry, can you repeat the question?
Surely. So the question is, why is cessation such a neglected area of our work when it's truly the main goal of everything that we're doing as tobacco control and public health professionals?
Gosh, I wish I knew the answer to that. Why is cessation neglected? By the tobacco control field. I think it's very, very unfashionable. It's very fashionable to protect kids. We must stop kids starting. We must, yes. But, saving kids, images of children suffering, much, much more fashionable. I think that there's a view amongst some in our field that adults who smoke and have smoked for many, many years have only themselves to blame. I don't think everybody understands how addictive nicotine is. So they're a kind of an invisible group, really. I mean, the longer term, the effects of smoking, tobacco use, mostly affect people later in life, in midlife onwards. And so they're a kind of an invisible group. I think that's a big part of it.
Liz, if I can add, I 100% agree with Martin, and to go further on the adults deserve it kind of thing, that we're partially to blame for that. The tobacco control industry for a long time behaved that way, behaved as if we got to stop these smokers from polluting our air, and it's their fault. But I think we should, and this speaks directly to using a human rights-based approach. We need to see people who smoke as our clients, and if we're trying to save lives, what bigger group of people is there that we should be focusing on than existing people who smoke, adult or otherwise?
And I think that speaks broadly to the question of what human rights can bring to this conversation, not just conceptually recognizing the ways in which all people are deserving of health, even those who are addicted to a substance, and to fix the environments in which they operate, but also to recognize tactically the ways in which human rights can help to extend this conversation. And speaking to the question that Chris was asked earlier about treaty bodies, I think one of the reasons that human rights advocates don't engage with these treaty bodies is because they haven't seen the impact yet. And so there is this chicken and egg problem. We can't have an impact of treaty bodies unless advocates are reporting into treaty bodies. But what we've seen in other areas, from children's health to water and sanitation to focusing on infectious disease, is where advocates are participating in this treaty body process. Treaty bodies are developing concrete recommendations for states that are giving advocates additional pressure points in order to change policies. So we need to begin thinking about how we can assess the effectiveness of treaty body work in tobacco control to give tobacco control advocates not just a conceptual reason to engage with the human rights system, but also a political or a tactical reason to engage with the human rights system.
Excellent points from all of you. Thank you. So we do have a diverse audience here today, but I am noticing a number of US-based participants that are with us today. And Chris, I'm going to go back to you, and then we may need to wrap up. Can you just remind US advocates, given that the US is not a party to the FCTC yet, just remind them of things that they can do in terms of how they can talk about the Article 14 and then the other human rights treaties that we have ratified. I know you touched in your presentation, but if you could just summarize for our US participants quickly.
Sure. I think it's fairly simple. It brings an additional argument to the table. And when you're talking to decision makers, a lot of them do care a lot about health, but some care more than others. And there are folks out there, city councilors and state representatives that care about human rights or health equity without necessarily caring about tobacco control. But this could bring them in. And the same goes for environment and a right to a healthy environment. I know in California's endgame work, we're really pressing the environment right now because that's what's capturing people's attention. And some of the environmental groups have been instrumental in pushing forward cutting edge policies on tobacco control. And I think we need to keep using that broad-based approach and find the arguments that bring in the biggest coalition that we can.
Thank you. Any other questions from our audience before we wrap up? Or any other words of wisdom from our panelists before we close?
I would only flag Carolyn's comments in the Q&A right now, and to recognize that this is an evolving conversation. The article was intended to start a conversation leading into COP10, and I hope that people will continue to engage around some of these human rights issues, both what they can bring to tobacco control generally and what they would mean for cessation specifically.
Thank you, Ben. Martin?
Not really. Just thank you very much for bringing this to people's attention. Let's hope that the human rights dimension can have an effect, an impact.
Absolutely. So we have made reference to the article in addiction. I believe that our production team has dropped the link to the article in the chat box. I'd also just like to remind you that we'll include that with the slides and the recording of our presentation, which will be made available via email probably later today. Also want to take a second and invite you all the participants here to join us on April 13th. Our Stop Tobacco Product Waste Alliance will be meeting to discuss our initiative with the UN Plastic Pollution Treaty. Main goal there is to see what can be done on a global level to ban cigarette filters. So stay tuned for that. And the signups will also come out via email over the next couple of weeks. Again, that's on the April 13th. If you haven't already, please do follow us on our various social media channels. We do have these ongoing series of webinars. Our next one again will be on April 13th. In our website, our Tobacco and Human Rights Hub, located at ash.org/HR hub, has a number of wonderful materials and references and things that you can use as advocates on the topic of tobacco human rights and of course cessation, as we discussed today. And it is now coming up on the hour, so I would like to just, before I conclude, I'd like to thank you, all of our excellent panelists, Martin Raw, Ben Meier, Chris Bostic, for your excellent presentations in the Q&A today. That was a wonderful discussion. Thank you to our partners at the NYU School of Global Health, also our partners at UNC School of Public Health for all that they've done to promote and make this webinar today possible. And of course, our production team at Action on Smoking and Health, Megan Manning and Nichelle Gray, for all that you've done to produce our event today. Thank you all. Thank you everyone for coming. Thanks to all of our participants, and please stay tuned for updates from us over email. Enjoy the rest of your day and your evening. Thank you.